Thanks so much. I'd like to thank SAGES for inviting us to present our work. Again, my name is Cornelia Griggs. I'm a pediatric surgeon at MGH, and I'd also like to thank my co-authors, Jeff Zeitzman at Columbia, where I trained for my pediatric surgery fellowship, and Numa Perez is one of my co-panelists today. The authors have no disclosures. As many presenters have discussed here today, pediatric obesity has become a major global health concern. The US prevalence has climbed over the past decade to affect over 14 million children and adolescents, comprising nearly 20% of the pediatric population. Metabolic and bariatric surgery is a safe and effective treatment option in children, as we've just heard. It benefits not only weight loss, but cardiometabolic health and weight-related quality of life. Despite the proven benefits of this intervention, fewer than 4 per 10,000 eligible children and adolescents currently undergo weight loss surgery. And there's no clear consensus on optimal timing. We know, as we heard just a minute ago, that the Teen Lab study gave us great data understanding the safety and efficacy of these procedures, and also gave us data showing that younger age at surgery was associated with higher probability of resolution of cardiovascular risk factors. Still, there are major barriers to children and adolescents undergoing weight loss surgery, and this is mostly made up of a lot of implicit and explicit bias against weight loss surgery in the pediatric age group. There's also a lot of fear and poor understanding of the safety profile of this operation and the benefits that can be gleaned. Insurance approval remains a major barrier, as well as access to high-quality centers of excellence and surgeons who are willing to perform procedures on children. Prevention and lifestyle is the backbone of the pediatric medicine approach to weight loss. And so there is a persistent bias against weight loss surgery and even medical interventions in much of the pediatric community. As we've heard earlier this morning, the COVID-19 pandemic only served to exacerbate many of these barriers. This is a study from 2009, but I think a lot of the perceptions hold true today. The authors were Iqbal et al., and they did a survey of 61 pediatric physicians trying to understand perceptions of weight loss surgery in the pediatric community. At the time, in 2009, there was a lot of concern about unknown long-term effects, and we now have great 5- and 10-year long-term outcome data to dispel a lot of those concerns, as well as with the operative risks. But just age alone was a big concern among a lot of pediatricians who were surveyed in this study, as well as a persistent problem that it was a lack of existing pediatric bariatric programs nearby, and this remains an ongoing challenge. This figure shows a lot of parent concerns about weight loss surgery in the pediatric community. This was a survey distributed by Mott Children's Hospital in 2011 nationally, and you can see that only a small percentage of parents would even consider weight loss surgery for their children under age 18. There was a major shift in the pediatric community attitude towards weight loss surgery in 2019 with the AAP policy statement, and they stated unequivocally in that statement that current longitudinal studies evaluating safety and efficacy endpoints did not apply specific age limits for the timing of surgery. Thus, there is no evidence to support the application of age-based eligibility limits. Now I'd like to spend some time discussing a recent paper published in December of 2021 by Dr. Al-Qahtani out of Saudi Arabia. And this was a really remarkable paper giving us 10-year outcomes in the pediatric age group. And it showed sustained weight loss and no decrease in growth velocity among over 2,500 children and adolescents for up to 10 years following laparoscopic sleeve gastrectomy. And what's really important about this paper is they included over 800 patients who were prepubertal under the age of 15, and they had patients as young as 5 years old. This is their visual abstract, and we can see here that the safety and efficacy profile is similar to that of adults in previously published literature in children. They had 27 adverse events, including 2 staple line leaks, 3 patients with metabolic neuropathy, and 22 patients who represented with nausea and vomiting. There was significant lasting weight loss with 70% excess weight loss at 10 years, and this was durable. There was durable resolution of associated medical problems, including 72% remission of diabetes, 58% remission of hypertension, and 57% remission of dyslipidemia. And what's really remarkable about this study is they also showed normal vertical growth velocity. And I'd like to take a second to focus on those results because it remains a major concern among parents in the pediatric community. This table shows the growth rate experienced by children and adolescents who underwent laparoscopic sleeve gastrectomy. They broke up the patient cohort by ages 5 to 14, the prepubertal group, and the postpubertal group at 15 to 21 years, and they showed no significant difference in height Z-score change, which means we can expect a normal vertical growth velocity for children, even if they haven't achieved total skeletal maturity at the time of surgery or intervention. I want to take another moment to focus on the resolution of comorbidities, because as we understand it, beta cell function declines by up to 35% yearly in those with type 2 diabetes, and timely bariatric intervention can save residual beta cell functioning. Earlier resolution of hypertension may halt dangerous vascular remodeling, specifically intimal fibroplasia and hyaline arteriosclerosis. These lead to long-term benefits to children that improve their health over a lifetime. Now I'd like to take a brief moment just to focus on the data that we collected out of New York, where I did my fellowship with Dr. Zeitzman. We looked at a prepubertal cohort of 57 patients. The average age of entry into our program was 13 years, with average pre-op period lasting about 8 months, making the average age of entry at the date of surgery 13.7 years. The minimum age was 9.6, and all patients experienced net weight loss. This is a table summarizing our results that I'd be happy to discuss further, but we had no operative mortalities. 2 patients did suffer postoperative complications requiring reoperation, including 1 intra-abdominal bleed and 1 splenic infarct resulting in abscess, and 1 readmission due to thiamine deficiency. But we also saw resolution of other associated comorbidities, including depression, obstructive sleep apnea, and idiopathic intracranial hypertension as early as 6 months. To summarize, the safety and efficacy profile in prepubertal patients is equivalent to postpubertal. There's normal growth velocity post-op, and long-term outcome data demonstrates a durable excess body weight loss. And I'd like to ask everyone just to take a moment when we begin to understand obesity as a disease and not a moral failure. We understand that eligibility for surgery is based on disease-based criteria, not on age. Thank you so much.